Ladies and gentlemen, it's another wonderful recorded lecture. This one is chapter 6 from the Merrill's Atlas. It's on the shoulder girdle. Now that's why isn't it just called the shoulder? Well, that's actually it's an anatomical term or an anatomical category. The shoulder girdle is technically comprised of the scapula and the clavicle. The proximal humerus is not part of the shoulder girdle. So you can think of it like a girdle that a lady wears is to wrap around her and kind of shrink her waist. And so it kind of binds and holds. Well, the shoulder girdle is the anatomy that binds and holds the upper arm to the torso. And so the humerus, being part of the upper arm, can't be part of the upper arm. So the shoulder girdle, when we say the shoulder girdle, it shouldn't be it shouldn't be casual. You shouldn't interchange shoulder and shoulder girdle. The shoulder girdle specifically refers to the clavicle and the scapula and the muscles that hold the humerus onto the torso. Okay. The shoulder also includes the humerus. All right, let's get into it. So we're going to talk about the anatomy of the shoulder girdle. We already did the anatomy of the humerus in the elbow and humerus lecture. Okay. Some of the proximal anatomy of the humerus will be discussed again, but primarily the focus is on the scapula. The clavicle really, it's got a curve in the middle. It's got a proximal end and a distal end. That would be a sternal end and an acromial end, and that's about it for the clavicle. Scapula's got a lot of piece parts, so most of the anatomy review is going to be focused on the piece parts of the scapula, both from the anterior aspect and the posterior aspect. It's good gravy. Sorry about that. Yeah, someone's shouting through my wall. Okay. So yeah, the scapula, on the posterior aspect of the scapula, there's actually quite a few points of anatomy to consider. It's got more features to it on its posterior side than it does the anterior side, but we'll get into that in the first few slides. As always, as we're considering procedures, we got to consider how do we prepare our patient and what kind of general considerations do we have to make? Are we going to stand them up or sit them down or lay them down? The shoulder can be imaged in all three of those formats. Typically we do them standing, but if your patient's not able to stand, all of these projections can be converted to supine projections for the case of trauma. Okay. Radiation safety practices, no reason not to shield a patient for a shoulder. We're nowhere near the reproductive organs, and the reproductive organs can be protected with additional lead shielding. And in addition to just applying a shield, we can also center correctly, position correctly, so we're not doing repeats, and collimate appropriately, so we're not exposing tissue that is not being evaluated for the exam. Okay. So typically we're talking about, let's get all the clavicle, let's get all the scapula, let's get the proximal half of the humerus or proximal third of the humerus, but we don't need to see the bones of the neck. Okay. We don't need to see all the rib cage. We don't need to see all the sternum necessarily. And so we can limit the size of the field of view to roughly a 10 by 12 field crosswise for most of these. Scapular Y, you're going to want to go 10 by 12 portrait orientation or vertical orientation. But most of the other views of the shoulder is 10 by 12 crosswise. So, and for smaller patients, you can collimate down from there. Proper use of positioning aids. If you are doing a supine examination of the shoulder, you can use 45-degree angle sponges for both the scapular Y view and the Gracie method, and roll the patient's pelvis and hips into 45 degrees side down and side up to get those oblique views of the shoulder and the scapula. Simulate examinations of the shoulder on a person or phantom in a laboratory setting. I think we're getting to that next week. We're going to start that next week, and because this unit kind of bridges over the winter break, we will do a repeat of that lab when we get back from our holiday break on January 2nd or so. One of the first things I do was to make sure it's just a lesson learned from previous classes. So I'm going to teach you this, and then you're going to have Christmas or Hanukkah or whatever family gathering you happen to celebrate. You're going to have that, and you're going to get a massive. If you thought holiday brain for Thanksgiving was bad, holiday brain for the winter break is awful. And so basically I have to do this positioning lab twice. So you guys will get plenty of practice and demonstration with shoulder projections. All right. Okay, so like I said, the shoulder girdle, when we say the word girdle, it means just the clavicle and the scapula. Okay. Now the articulation is, the primary articulation is between the head of the humerus and the glenoid fossa of the scapula. That's that thing that looks like a mesa. Turn it sideways, you'll see. It looks like a mesa. The manubrium of the sternum articulates with the proximal end of the clavicle or the sternal end of the clavicle to form the sternoclavicular joint. And then the clavicle and the sternum, or I'm sorry, the clavicle and the scapula form an acromioclavicular joint superior to, and just a little bit medial to, the humeral head. So almost directly superior to the glenohumeral joint, which is what we think of as the true shoulder joint. But all of these joints are involved with the motions of the shoulder. Your clavicle kind of moves up and down at the distal end. Okay, your scapula rolls, kind of like flares outward as you raise your arm up. And then, of course, the glenohumeral joint is a ball and socket synovial joint. Sorry about that. Mr. Shepard's phone is ringing. Yeah, like I was saying, the glenohumeral joint is a ball and socket joint allowing for multi-axial movement. Okay. The shoulder, not the girdle, is the articulation of the upper limb with the girdle. The humerus is not part of the shoulder girdle. The humerus is what is being bound up by the shoulder girdle. So while it's not technically part of the shoulder girdle, proximal humeral anatomy is considered in evaluation of images on the shoulder joint. So the radiologist doesn't care that it's not part of the shoulder girdle. The radiologist wants pictures of the whole shoulder, including the proximal humerus, which would be about the proximal third of the humerus. Okay, and you can just see some of the soft tissue structures. We have a I've clipped off those three. There's the acromion, subacromial space. I think that's a bursa, might be a synovial cavity. There's the rotator cuff. That's one of the unlabeled ones. There is I think that's the deltoid muscle, on top unlabeled one on the left. I think that's the deltoid muscle. And then that's a synovial space. That synovial space, I believe, is the rotator cuff. I think that's the biceps tendon there. That third one, unlabeled third one on the bottom, I believe that's the biceps tendon. Goes over top of the humeral head, and it looks like it tethers to the coracoid process. And then there's the shaft of the humerus, there's the head of the humerus, there's the glenoid fossa, and the main shoulder joint is the capsule of fluid in blue between the glenoid fossa and the head of the humerus. But it looks like there's several capsules of synovial fluid in and around the shoulder, and that just promotes friction-free motion when all the parts, because every time you raise your arm, your humerus is moving, the surface of your humeral head is moving wildly relative to your glenoid fossa. And so we need a lot of fluid pocket and synovial space to allow for such a variety of movement as is capable in that shoulder joint. Okay. The shoulder joint, and this joint is also known as the glenohumeral or the scapulohumeral joint, is diarthrodial. Okay, that means completely moving. It's synovial. That means it's surrounded by a fluid-filled membrane, and it's a ball and socket type, capable of all motions. Well, almost all motions. Depends on how young and healthy you are. So, the sternoclavicular joint also technically includes the first rib cartilage, and so watch for that on upcoming quizzes. Sternoclavicular joint proper is the manubrium of the sternum, the proximal end of the clavicle, and the first rib cartilage. It's all connected together into one joint. Okay. Our clavicle, real quick. It is a long bone. It lies above the first rib. It's got a lateral end or a distal end or an acromial end that articulates with the acromion. And then it's got a sternal end, which is also the medial end or the proximal end, and that articulates with the manubrium of the sternum. And that's about it. And it's got a little S curve in the middle of it. And if you've broken it right at the S curve. Okay. Yeah, there we go. The acromial extremity is a little bit wider. The sternal extremity doesn't look like it has much of a condyle to it. It's more just blunted off right there. And then the body, of course, is the S curve, diaphysis, and right where that body indicator is typically where the fracture happens if you're going to break your collarbone. Okay. Looking at the scapula, this is from the anterior aspect here in the diagram. And I know that because I can't see the scapular spine. That's on the posterior of the scapula. So we have the scapula is roughly shaped like a triangle. It has a lateral border, a medial border, and a superior border. Okay, and then at the where the two sides of the triangle meet, then of course you get an angle. So you have a superior angle and an inferior angle. The inferior angle is not labeled here, but it's between the lateral border and the medial border, and it lies at the level of T7. We learned that in the chest x-ray. There's also a lateral angle, technically. The glenoid cavity or the glenoid fossa is sometimes referred to as the lateral angle of the scapula, even though it's not a true angle. It kind of loses its triangularity over there on that side. So the glenoid cavity is the top facet surface that articulates with the head of the humerus. It is kind of bowl-shaped or cup-shaped. And then the neck of the glenoid is the part that I say looks like a desert mesa. Just tip your, right now, looking at this slide, tip your head all the way to the left and you can see the desert mesa. Okay, you know, just a big, you're riding on your horse through the desert, and there's a big rock in the distance, and it goes vertical until it gets to the top, and then it's flat on the top. That's what a mesa is. Okay. The acromion is a posterior process on the lateral aspect of the scapula. The anterior process is the coracoid process. Merrill says technically you can palpate your coracoid. I have not been able to do it consistently without. I've been able to find it occasionally, but you have to dig so deep that it ends up hurting. So I typically don't recommend my students try to palpate the coracoid process. There's at the base of the coracoid process, there's a scapular notch. Think about like the back sights on a rifle. If you're shooting iron sights, there's the peg, which is the front sight, or the stick, and then there's the back sight, which is the groove or the notch. So scapular notch is very much like the back sights, iron sights on a rifle. Okay. The acromion does turn into the scapular spine. We'll see that on the when we flip this around and look at the posterior diagram. Okay. Yeah, it kind of looks like an axe, doesn't it? And you think the shape of an axe head is an accident. No, that's probably, the first axe was probably a scapula. Maybe not a human, maybe a pig scapula, but the first axe blade was probably a scapula. That's probably where that shape came from. So, all right, here's our posterior aspect. Okay, so there's a costal surface and a dorsal surface to the scapula. We already looked at the costal surface, that is the anterior surface. This is the posterior aspect of the scapula. There's the inferior angle. We've labeled it now. Okay. Medial border and lateral border haven't changed. Superior border hasn't changed. Scapular notch hasn't changed. Now we can't really see the coracoid because that's the anterior process, but we can see the acromion that descends all the way down to become the scapular spine, and then there's a prominence. If you are hyposthenic or asthenic, you can actually walk back from your acromion back onto your shoulder blade, and you can probably palpate the your scapular spine if you are hyposthenic or asthenic. Once you get to the larger habituses, there's just too much adipose tissue covering the scapular spine, but it can be palpated on some people. So there's your lateral angle. Technically, it's the inferior corner of the glenoid cavity. And then again, there's the glenoid cavity, there's the neck, that's still the desert mesa. Okay, turn your head to the right this time, you can see the desert mesa. Okay, and then the fossas, which are, remember, those are hollowed out sections or depressions in a bone. There's two fossas. There's one that's above the scapular spine, and then there's one that's below the scapular spine, and that's exactly how they're named. If you break apart those words, using your medical terminology skills, you will see that supraspinatus, or supraspinous rather, supraspinous fossa means a hole or a depression superior to the spine. Yeah, that's exactly what that is. It's a little hollowed out section of the scapula, immediately superior to the scapular spine. And then the infraspinous fossa is a depression or hollowed out section that is immediately below the scapular spine. That's exactly what infraspinous means. So if you understand the medical terminology, those are easy to remember because they describe exactly what they are. They are little depressions on either side of the scapular spine. One's above it, one's below it. So not hard to remember. Once you do the work on the medical terminology, break the word apart. Spinous means considering or pertaining to a spine, and then supra means above a spine, and then infra means below. And so one of the fossas is above a spine, one of the fossas is below a spine. Couldn't be more straightforward. Palpable landmarks before I go into general procedure guidelines. The acromioclavicular joint, the inferior angle of the scapula, the proximal end of the clavicle, the medial edge or the medial border of the scapula, and occasionally the scapular spine. All of those can be palpated without too much discomfort to the patient. Okay. Patient preparation. We are going to need them into a gown, particularly the female patients, because we'll have them remove their bra, underwires, and adjustment straps on top of the shoulder will produce artifacts. And also, if the over the shoulder strap is tight, then that will produce an extra skin fold right in the area of the acromioclavicular joint. So the bra is just artifact prone and needs to be removed. And so we'll have the patient take off everything from the waist up, including bras and necklaces in particular. Sometimes hanging earrings, just, if it's obvious that the earring is hanging, it's going to be like 4 inches of dangling to get down to overlying the clavicle. So if it's just, you can see that it's going to be a problem from across the room, have them if it's posts, don't worry about it. But if it's like excessively hanging down, where it's like the end of the earring is draping across their shoulder, well then that's got to come out. That's going to produce an artifact. So by and large, earrings don't have to be removed, just the excessively long ones, I guess, or the big hoop. I guess big hoops went out of style sometime in the 90s. I haven't seen big hoops in a while, but just anything that's accessories or clothing that's possibly could show up. Some of the sparkly sequins and sewed in beads to some of the decorative blouses that women wear, those sometimes show up on x-ray too, so watch that. Okay, going into patient preparation, general patient position was standing. Patient preparation was everything from the waist up, especially the necklace. The necklace will get in the way of the clavicle, okay, and possibly the scapula, but definitely the clavicle. And then, of course, nipple piercings might overlie the inferior angle of the scapula and the inferior structure of the scapula. So be mindful of that. General patient position. Typically, we're going to do these upright unless the patient's been in some kind of trauma situation like a car wreck where it's not a wise idea to stand them up. Or if they're just failing your Hendrick fall scale and they're just too weak to stand up, You can do these sitting in a wheelchair, sitting in a stretcher, or laying down on the exam table. These are the shoulder is pretty versatile as far as doing the imaging on it. Okay. IR collimated field size I already addressed. Most of our projections are going to be 10 by 12 landscape style or crosswise style. And that's so we can get all of the clavicle. The exception is the scapular Y view. The clavicle is not the area of interest for a scapular Y projection. And so we can go portrait style 10 by 12 view. You can collimate in side to side quite a bit on a scapular Y view. Attempting to collimate on some of the other views might be problematic. You might end up clipping anatomy. So your SID is 40 inches. For most of these projections, I think the AC joints, the Pearson method, we're going to go back to 72 inches just so we can fit both AC joints on one image receptor. ID markers, obviously there's a difference between the left and the right shoulder, so make sure you're using a radiopaque ID marker. Digital markers do not meet the legal standard for identification of X-ray images. Radiation protection we already addressed. Excellent collimation. Only include the anatomy we need. We do not need a cervical spine on our shoulder X-ray, nor do we need the entire rib cage on our shoulder X-ray. So proper collimation, no reason not to shield the patient, and remember to tell the patient to hold their breath because there will be breath motion if you do not have them suspend respirations for these projections. Okay, the exception is going to be the transthoracic lateral projection. We could possibly do a breathing technique for that one, and I'll talk to you about what a breathing technique is in laboratory demonstration. All right, so like I said, jewelry, artifacts, bras, bra hooks, buttons, all that kind of stuff. Secure your patient belongings. Remember, necklaces are sometimes worth more than you make in a year, especially with all the country music stars we have gallivanting around town. So watch out for that. Never take possession of anything valuable that the patient has. Always hand that off to a family member and document that you handed off to a family member. Or if no family member is available, then call security to take possession of the valuables while the patient is unable to. So like, if it's really expensive jewelry and the patient got in a car wreck and they're not really conscious, the ethical thing to do is to take the jewelry to security, and that way you did your best to prevent loss or theft. And then of course document that, have the security guard acknowledge that you turned that in, and both of you guys document that, or girls or whatever. The point is, make a document of the chain of custody for those valuables. It will save your butt on the back end, okay? Especially if they come up missing after security takes possession of them. Well, I've got this signed piece of paper that says I handed them off to Brad, and it's got Brad's signature on it too. And so he and I agreed that I handed these pieces off. And so I don't know where they were. Last I knew, Brad, the security guard, had them. And see, then you're off the hook. So just take a little advice from Mr. Tillotson. You don't want to be held liable for patient valuables. Okay, bad things happen when patient valuables come up missing. All right. So shoulders can be performed upright or recumbent, or seated. Yeah, you can do it seated in a stretcher or a wheelchair. Might be a little tricky to pull off some of the positions in a wheelchair, probably better in a stretcher, but you can also lay them down if they're not, if they don't have enough energy to stand or not well enough to stand. You can lay them down on the exam table and do these. Consider patient comfort first, especially if your patient has a broken arm. Let's do our best not to move the broken arm because the brachial artery is like right up next to the diaphysis of the humerus. So I really don't want your patient bleeding out on you from an internal hematoma. So let's try not to manipulate. If we take an X-ray and we see definitively that there's a fracture of the humerus, let's not manipulate that. Let's try to find a way to take the rest of the pictures without manipulation. Okay. SID collimated field size 10 by 12 is your recommended field size or cassette size. And the SID is standardized at 40 inches for most of these projections. You're going to have trouble with that. With this, that's called the Lawrence method. Axial lateral, inferior superior axial lateral is how that's described. And Lawrence had two methods. The transthoracic lateral is also a Lawrence method. And so we usually don't call them Lawrence. We usually call them inferior superior axial lateral or transthoracic lateral. Okay. ID markers, yeah, use lead markers, mark outside the pertinent anatomy. That means don't cover up the clavicle, don't cover up the humeral head or the proximal 1/3 of the humerus. Don't cover up the scapula. There should be the upper outer corner for most of your projections should be wide open, and the shoulder generates enough scatter that it will paint your marker with a little bit of extra radiation. See how dark it is out there? That's because you're getting raw primary beam plus scatter radiation ricocheting off the shoulder up there in that corner. So the marker will show up with high contrast in that upper outer corner. Radiation protection. There's no reason not to shield, okay? The gonads are nowhere near the area of interest. No reason not to shield, okay? Close collimation, optimal techniques, factors, and then also position correctly the first time. You do those three things, you don't have to repeat, okay? Don't clip the anatomy, but don't expose unnecessary anatomy, okay? You know where the sternoclavicular joint is. Open the light past the sternoclavicular joint by about 3/4 of an inch, and you're good. You know where the inferior angle is. It's at the level of T7. Make sure the light field goes down below the inferior angle of the scapula, and you're good. Okay? You can see the outline of the deltoid muscle as it casts a shadow. Make sure you haven't clipped the deltoid muscle. The humeral head it's like a Tootsie Roll. The deltoid muscle is the lollipop. The humeral head is the Tootsie Roll pop, is the Tootsie Roll center of the Tootsie Roll pop, okay? It's inside the deltoid muscle. The deltoid muscle completely surrounds, almost completely surrounds the humeral head. So if you have the deltoid muscle on your radiograph or in your exposure field, you definitely have the humeral head in your exposure field. See how that works? All right, someone tell Ali what a Tootsie Roll Pop is, or better yet, someone bring in Tootsie Roll Pops for all of us. That would be great. Thanks. All right, patient instructions. Explain and demonstrate positions and breathing instructions. And so you don't really need to demonstrate breathing instructions, just tell them to hold still, hold their breath. But you do want to model some of these pictures. Again, modeling is a very powerful tool for getting your patient quickly into the correct position. Just show them how you want them to position their arm. Now be aware for trauma, a lot of times the answers can be, no, I don't think I can do that. It's going to hurt too much. Okay. This is the first, well, the humerus was actually the first, but respirations are now affecting the position of the anatomy and whether or not the anatomy is moving. Okay, and so most of the time we do prefer suspended respirations. It doesn't have to be on inhalation or exhalation. So the right answer to the quiz question this time is actually suspended respirations. Okay. A transthoracic lateral projection may use a breathing technique. Basically, a breathing technique is a extended exposure time. So you reconfigure the mass so that the exposure time is the big number, like 2.5 seconds long. And then you tell the patient to breathe normally while the exposure is going on. And what happens is the rib cage oscillates in and out and up and down, and you end up blurring out the ribs because of the motion of the rib cage during the exposure. Okay, if you take a quick exposure, less than a second, the breathing technique's not going to work. You need an extended exposure to get a couple of cycles of breaths and really make those ribs oscillate and move. Okay. All right, so what projections are we going to learn? Well, there are actually 3 AP projections: internal and external rotation. Finally, we named those correctly. A neutral position, which is halfway between internal and external rotation. And internal and external rotations of the AP shoulder are going to look familiar to you. It's going to look like humerus positioning to you, but we're centering to the shoulder joint rather than the humerus. All right. Yes, in addition to the AP projections, you're going to see a Gracie method, or Grashey, depending upon who taught you how to say that word. It's an AP oblique, and it's always affected side oblique down to the image receptor. So if we're doing a right shoulder Gracie method, it would be an RPO. Okay, if we're doing a left shoulder Gracie method, it's going to be an LPO. Okay. A transthoracic lateral Lawrence method, we'll call it transthoracic lateral. You're not going to do that all the time, but you are going to utilize the transthoracic lateral when there is, when there is a fractured humerus or some kind of fracture injury, and we can't manipulate to an internal and external rotation. It's not safe to manipulate the humerus because it's broken. We should substitute a transthoracic lateral. The inferior superior axial Lawrence method is now being included in a routine shoulder projection or a shoulder series in several of our sites. And so I'll teach you how to do both versions of that, the inferior superior and the more common superior inferior, where we just reverse the direction of the central ray. Have the patient sit on a chair on the side of the table and abduct their elbow over the cassette, and then you shoot down through the top of the shoulder. The PA oblique scapular Y is also a routine view. And then a non-essential projection that I must include because the curriculum demands it. We're teaching now for the second year we're teaching this. This is called the NIR method. I have never shot a NIR method on an actual patient myself, but I'm going to show you how to do one so that you can add that to your repertoire of available projections that you know. Okay. All right, so if we're going to do an internal rotation, rotate the patient slightly toward the affected shoulder, place the body of the scapula parallel with the plane of the IR. You especially need to rotate a patient who has kyphosis. So the sweet little old lady that can't stand up straight anymore, and she's stooped forward at the upper thoracic spine, yes, roll her quite a bit to get a true AP of the shoulder, because her shoulder is aggressively oblique now. Okay. Part position, flex the elbow slightly, rotate the arm internally, rest the back of the hand on the hip. I have a little teacup. Oh, I'm sorry, I need to change that to teapot, don't I? So I still need cited evidence from Haley. So she hasn't sent me the email. I'm becoming disappointed in her. Anyway, humeral epicondyles will be perpendicular to the IR for the internal rotation of the shoulder. On the internal rotation shoulder, you will see the lesser tubercle on the medial aspect of the humeral head in profile. Okay. And so where do we direct our central ray? Well, it's going to be perpendicular 1 inch inferior to the coracoid process. Now, I mentioned previously in this lecture that it's very difficult to palpate a coracoid process. In fact, you could hurt your patient if you try to dig for it. So just center to the depression, the little, there's a little dip in the skin right on the inside of the shoulder. That little depression is basically 1 inch inferior to the coracoid. So just center for the dip. Okay. Column 8, 10 by 12, crosswise. You should include the shoulder. You should include all of like the upper third or the proximal third of the humerus. And then the little, oh, look at the little black triangle. That's pointing to the lesser tubercle. The black arrow is pointing to the greater tubercle that is in fact superimposed over the middle of the humeral head for an internal rotation. Okay, so one of the things on the quiz in January is I'm going to show you this picture or the external rotation, and you ought to be able to tell the difference and tell me which one's which. Okay. We want the sternal end of the clavicle, which is clipped on this radiograph, I'd like to point out. We also want the inferior angle of the scapula. I know the book doesn't mention that anymore. They used to, and the scapula is part of the reason we do a shoulder exam is for broken scapula or fracture of transverse fracture of the shoulder blade. If you're clipping off the lower half of the shoulder of the scapula, you haven't done a thoroughly diagnostic exam, in my opinion. All right. AP projection with external rotation, same position. We just have to turn the patient's arm outward. And so this is hitchhiker. Okay. Rotate the arm externally, supinate the hand. They don't have to stick their thumb out like they're hitching a ride, but it's an easy way to convey the instructions to the patient because most of your patients will understand what you mean by stick your thumb out like you're hitching a ride, and they'll get right into the correct rotation position. Okay. When they do that, when they supinate the hand, the humeral epicondyles will now be running parallel to the image receptor. So very much like for the AP humerus, the external rotation of the shoulder presents just like an AP humerus and positions just like an AP humerus. The difference is, again, we're centering for the shoulder joint 1 inch inferior to the coracoid process. So there's your centering. Yeah, you can see just in that little depression area of the skin right there. Okay, like at the very top of the pectoral muscle. I really wish they would have given the directions subclavicular. That would have made more sense because you can actually palpate the clavicle. Okay, again, collimation 10 by 12 crosswise. Make sure you're including all of the clavicle, which we did not here. We clipped the proximal end and all of the scapula. Okay, he's got way too much light field above the shoulder, in my opinion, for this one. We could have dropped it down, probably dropped that down about 1.5 inches from where he's centered. In neutral projection, or excuse me, neutral position rather, basically shoot it as it lies, okay? This is when the patient is in great deal of pain, has had an acute trauma injury, and you are suspicious for fracture of the humerus somewhere along the diaphysis, okay? If the patient is having trouble moving the arm and they're in the guarded posture, just shoot it as it lies. Don't try to roll the humerus externally or internally. You could exacerbate the injury, okay? The epicondyles should be roughly at a 45-degree angle to the image receptor for the neutral, but again, we don't want to do manipulation, okay? Center ray directed the same as for the other two AP projections. You don't often do a neutral. You do a neutral when you can't do an internal or an external, okay? 10 by 12 crosswise, include all of the clavicle and all of the scapula. All right, so what is the lateral thickened end of the scapular spine called? Is it called the acromion, the coracoid, the coronoid, or the glenoid? Each of those a process except for letter A. Shall I sing the Jeopardy theme song? Do, 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 do. It's choice A. The acromion is the lateral thickened end of the scapular spine. Remember, the scapular spine is on the posterior aspect of the scapula, and it just keeps progressing from the medial border to the lateral border or to the lateral angle, and then becomes the acromion at the most lateral margin of the scapula. There it is. There's the acromion at the end of the scapular spine. Wow, what a nice animation. Fancy. This is a high quality education you're getting here. Okay, let's do a Gracie. A Gracie or a Gracie, depending upon, again, who taught you and how they pronounce that. I've heard it both ways, and I honestly don't know which way it's supposed to be said. If somebody could find that out for me, that would be fantastic. Okay. Patient position, supine or upright, and it is an RPO or an LPO, depending upon. It's always the affected side down, oblique is what it is. Okay, we're not going to do a true 45, more like a 35-40, 35 to 45 degrees. It does depend on habitus. Your hypersthenic patients, the scapulas are going to be, is it less or more? I think they're going to be more flat and require less obliquity. And so the asthenic patient, the scapula is going to be more oblique in the AP, and to flatten out the scapula, you'll have to turn them or rotate them more than the hypersthenic patient, okay? So now typically you don't really measure the degree of rotation, you just rotate them until you can feel that their scapula is flat against the image receptor, okay? More rotation may be necessary if patient is recumbent. That's always true. The rotation should place the scapula parallel to the IR, excuse me, and that's how most techs determine that they've rotated them enough, is they see that the back of the scapula is laying flat against the image receptor. Head of the humerus will be in contact with the IR. Well, technically the posterior aspect of the deltoid muscle will be in contact with the IR. Arm position dictated by department protocol, or palm of the hand on the abdomen, which is the Napoleon stance, or an internal rotation. So typically internal rotation, sometimes, VA is switched now. They're doing internal rotation. The reason I put that in there like that, was the VA was doing external rotation Gracie methods, but I guess they're doing them internal rotation now. So give us a nice Napoleon pose. Tuck the palm of your hand into your vest or your waistcoat, or tuck the patient's palm of their hand, right across the belly button, right in the breadbasket, like they're trying to keep their hand warm, so they tuck it into their vest. That is a proper internal rotation for a Gracie method of the shoulder. Now, the Gracie is often called by the orthopods the true AP shoulder because it stands the glenoid cavity up on edge, and you can actually see an open shoulder joint, an open scapulohumeral joint right there in the middle. So that's why the orthopods often call the Gracie the true AP. Okay. So it's always affected side down, like we see our model demonstrating here. Again, I think they're centered too high in this demonstration. They got way too much light field above the shoulder, okay? But they are rotated. The patient's body is rotated somewhere between 35 and 45 degrees to the image receptor. Scapula looks like it's flat against the image receptor. The area of interest for this one is typically just the glenohumeral articulation, especially if you're doing other AP views of the shoulder. Maybe not necessarily. The clavicle is going to be foreshortened, so if you clip off part of the clavicle, you can collimate down just a little bit for this one, because the area of interest is specifically the glenohumeral joint, as opposed to the straight AP. We're technically evaluating all the bones, the proximal humerus, the entire scapula, and the entire clavicle in an AP shoulder. But this is specifically to evaluate the joint space of the glenohumeral joint. So we could collimate in a little bit. It does reflect that. 8 by 10 is plenty of field size for that. Okay, your transthoracic Lawrence method, that is the unaffected arm that the patient is raising. That's important. Okay, so the affected arm is the downside arm, or the arm closest to the image receptor. And so transthoracic means exactly what you think it means, pertaining to across the thorax. That is the projection. The central ray is going across the thorax to get a lateral humerus, a side view of the humerus. Now, techniquing this, you're just going to use center cell at about 80 or 85 kVp. You will keep the patient's opposite side arm relaxed so you can center appropriately first. You're going to center to the bottom of the deltoid muscle, or the intersection of the deltoid with the bicep and the tricep. That location is called the surgical neck of the humerus, and that's the center of this projection. Okay. Once you have centered to the opposite side surgical neck and you're sure that your patient is standing up straight, as you raise the unaffected arm out of the way, the central ray is still directed to the affected side surgical neck. And that's because when people stand up straight, they stand symmetrically. So the surgical neck on the unaffected side is basically at the same height as the surgical neck on the affected side. We want to center for the surgical neck because if the humerus is broken, that's the most likely location for a fracture of the humerus. That's why it's named the surgical neck. Okay. So the key thing of this one is the whole point is to not manipulate the affected side. Leave the patient's affected arm alone and raise the unaffected arm out of the way. Now you still have the rib cage to contend with, but you can use a breathing technique. The patient breathes, the ribs oscillate, and they blur themselves out, and you get a nice view of the downside humerus. The top 2/3 of it anyway. the diaphragm will cause significant attenuation, and you won't be able to see any of the parts of the humerus below the diaphragm for this projection. I have actually shot this one 3 times during clinical practice when I was a staff technologist at MTMC, and each and every time the radiologists were very appreciative of my expanded repertoire of positions and projections. So here's how your transthoracic lateral looks, and you can see this is with static breathing instructions. Okay, someone's shouting through my wall again. All right, sorry about that. So this is with static breathing. This is suspended respirations. The ribs are not blurred out, and the ribs and the lung markings are causing significant superimposition to the humerus. But you can see the humerus really, really well here. So you can see the clavicle. Oh, so there's a bunch of indicators here. The first one at the bottom, that's the easy one. That's the surgical neck of the humerus. That the next one up, it looks like it's pointing to the vertebral body, but I think it's pointing to the edge. It's pointing to the lateral border of the scapula more than it is the vertebral body there. So the third one from the bottom is the humeral head. That looks like, I gotta find my bearings here. The fourth one from the bottom, I think that's the acromioclavicular joint. Yes, the fifth one from the bottom, or the one next to the top one, that's the clavicle. And the top one, I think it's the first rib. So the top one's first rib, second one down is clavicle, third one down is acromioclavicular joint, fourth one down, humeral head, fifth one down, lateral border of the scapula, sixth one down, or the bottom one, is the surgical neck. And so we're centered to the surgical neck. The unaffected arm is lifted up out of the way, and the humerus should be framed like right in the top of what you would call the lateral chest X-ray. And so the spine should be posterior to it, and the sternum should be anterior to it. You should see the humeral head right in the center of those. Okay. Central ray is typically directed perpendicular. If the patient has trouble raising the unaffected arm, you can shoot this with a 10 to 15 degree cephalad angle to replace disposition of that unaffected shoulder. 10 by 12 portrait style, because the focus is the humeral head, and as much the glenohumeral articulation, the humeral head, and as much of the proximal humerus as you can include in the field of view. There is no point in extending the collimation below the diaphragm. The diaphragm and the liver are huge attenuators for this projection, and you do not see the distal humerus on this projection. That's where you need to go back to the chicken wing elbow projection to get the distal humerus. Okay. Do not collimate larger than the stated field size. And that's because you don't want a bigger than a 10 by 12 field, because then you're including more of the vertebral bodies and more of the sternum and the rib cage, and you're just going to generate more scatter, which will erode your contrast resolution on your image and put more noise on your image. And so keeping your collimation tight improves the visualization of the humerus on the other side of the thorax. All right, scapular notch is located. Is it on the medial border, the lateral border, the inferior border, or the superior border. Do 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 do. Do, 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 do. It is on the superior border, ladies. There is no inferior border of the scapula. There's an inferior angle. And so C was absolutely incorrect because that piece of anatomy doesn't even exist. The correct answer is D. All right, let's get into our first Lawrence method, the inferior superior axial lateral projection. Boy, that looks uncomfortable, and you will find out if you are the patient volunteer that it is indeed uncomfortable. In order to get the glenohumeral joint on there, you basically have to shove the image receptor into the side of the patient's neck. Now, I would recommend the low end of that angle, not the 30 degrees, but this is the angle that you use is dependent upon how much does the patient abduct the arm. And so if they abduct really well, then we're going to use a 30-degree angle, but if they can't abduct well, then we only use a 15-degree angle. Head and shoulder elevated on 3-inch radius. So yeah, you want to build the shoulder up off the table a little bit as you're doing this. And you also want to scoot them, the table position is wrong, scoot them to the edge of the table so you can drop your crane off the edge of the table and get the x-ray tube like shooting from about where they're halfway between their knee and their hip on the edge of the table, angling in toward their mid-sagittal plane. So would I say this is a cranial or a caudal angle? No, I'd say it's a medial angle rather than a cranial or caudal. Yes, I know it's heading right for his head, but it's kind of a deviation from a longitudinal angle at this point, and so it's angling medially. That's how I would describe it. All right, so this is what you're supposed to see. This is probably one of my favorite x-rays. A well-done inferior superior Lawrence method just looks so pretty because everything just sits just so. For example, you can see the lesser tubercle on the anterior aspect of the humeral head. Then this one is slightly off. The acromioclavicular joint is superimposed over the center of the humeral head, typically. When I shoot it, it is. I don't know who shot this, but when I shoot an inferior superior axial projection, the acromioclavicular joint is right on top of the humeral head. The scapulohumeral joint or the glenohumeral joint is open on a properly angled and positioned Lawrence method. You can see the coracoid process, you can see the distal end of the clavicle, and you can see the acromion on this view. And so two views at 90 degrees, this satisfies it. Now, if you have a trauma shoulder, good luck getting the patient to abduct their arm at all. Maybe try to substitute or ask if you can substitute an alternate projection rather than the inferior superior axial projection. So we say don't manipulate on fractured humerus or suspected fractured humerus. You also should not be manipulating suspected fractured collarbone and suspected dislocation or freshly reduced dislocated shoulder should also not be manipulated. Okay? This one in particular and an external rotation shoulder can dislocate a shoulder that was just put back in place by the orthopedic surgeon. You want to talk about a doctor that's going to get mad. That's the doctor that's going to get mad. He just put the shoulder back into joint. He asked you to take x-rays of it, and you manipulated it when you know you're not supposed to, and you popped it back out of joint with your manipulations. Yeah, he or she is going to be very upset with you, and justified. Don't manipulate a post-reduction shoulder. Okay. All right, so inferior superior axial projection. Well, this is mislabeled actually. This is superior inferior axial projection. And so you can do it, and the text, you've probably already seen this. The text don't do the other one. The text do this one, okay? And so what you do, now this is set up partially correct, but I can show you how to do it better than how they have demonstrated here, okay? This one is passable, but the table's too high in my opinion. You can get better centering of the shoulder joint if you lower the table. Okay? So it says center A horizontal, medial angulation 15 to 30 degrees. That's for the previous projection. For this one, we are going to do 5 to 15 degrees laterally, entering the AC joint. Okay? And then have the patient lean over the table, reach as far as they can over top of the image receptor, and then lean their head away from the affected shoulder. Okay? Because the x-ray tube is basically going to be right above their head, angling outward toward the elbow. Okay? Sorry that the words don't match the picture. Just listen to what I said. Okay. PA oblique scapular Y, time to run through. This is a different view of the scapula. This is a lateral aspect of the scapula, where this is basically the presentation of the scapula on the scapular Y projection. And so there's a lateral border and a medial border, and they should be superimposed. The coracoid process you should see anteriorly, and the acromion process and the scapular spine you will see posteriorly. The glenoid surface is actually going to be superimposed over the humeral head unless there's a dislocation. The PA oblique scapular Y view is the most definitive diagnosis of dislocated shoulder. The reason we do the scapular Y view is to evaluate for dislocated shoulder. Okay. Most commonly, it's an anterior dislocation, but you can occasionally do a posterior dislocation. Okay. Those are also called subcoracoid and subacromial dislocations. That might be an upcoming quiz question. I'll say it again. The anterior dislocation of the humeral head is also called a subcoracoid dislocation. The posterior dislocation of the humeral head, while it's more rare, it can happen. That is called a subacromial dislocation. All right, to do a scapular Y, it's basically the opposite of the Qureshi. We are going to turn the patient around, so it is a PA projection, and you're going to do an RAO or an LAO, this time with anywhere from a 45 to 60 degree angle. And again, the angle is dependent upon the patient and getting their scapula perpendicular to the image receptor. So the body of the scapula, you roll the patient till the body of the scapula is perpendicular to the image receptor. Just put the back of your hand, put your hand on the back of the patient and roll them until your hand is perpendicular to the image receptor, and that's enough obliquity. Now you can do this AP, but it introduces significant amounts of OID, and you're definitely going to magnify the scapula, and you might clip off the inferior ankle with that magnification, so be careful with that. I've never seen a PA oblique scapular Y clipped at all. So I have seen some AP scapular Ys clipped for magnification. Okay. Maintain patient comfort. Remember, it's the affected side is against the image receptor for this one, and so be gentle with them. And again, it's within the realm of possibility they have a dislocated shoulder, so maybe try not to touch the arm. If it looks dislocated, it probably is. All right, so your scapular Y. Well, that looks pretty good, except for the humerus is right on top of the body of the scapula. So this would be incomplete or non-diagnostic if we were looking for a transverse scapular body fracture. Okay, if we're only evaluating dislocation, this looks great. Okay, we could clearly see that the humeral head is centered over the glenoid. Now, where do you find the glenoid? It's at the very center of the Y. So you see the body is like the stem, I guess, of the Y, and then the acromion and the coracoid make the two tree branches, so to speak. And where they all intersect, that's the glenoid fossa. The humeral head is supposed to be superimposed over the intersection of the Y. Okay. You can collimate in side to side. You can also do manipulation of the humerus. You can roll it, not really roll it, more like redirect it, or have the patient, that would be adduction, and reach around and grab the opposite side shoulder with their hand, and then they adduct the humerus to the front of the torso, and that will roll the diaphysis, the shaft of the humerus, out of the way of the scapular body, and then you get a non-compromised view or non-superimposed view of the scapular body, and that's the way most of the texts will do it. You can also have the patient, if they're capable, they can do the fencing posture where they put their forearm in like on their lumbar spine in back of them, like a one-handed sword fighting stance. If they're capable of that, that will also move the shaft of the humerus out of the way of the scapular body. Okay. So as far as collimation concerned, we would like to see the AC joint at the very top of the image. You want to see all the acromion, all the coracoid, and all of the scapular body free of superimposition if you can. Okay. The humeral head is not going to get free of superimposition from the glenoid unless there's a dislocation. Okay. All right, supraspinatus outlet, the Neer method. So set up like you're going to do a scapular Y, and then invoke a 15-degree caudal tube angle, exiting at the top of the humeral head, or what I like to say is about a ½ inch inferior to the acromioclavicular joint. So that central ray basically skims along the top of the scapula, and then it passes through the space right underneath the acromion. Okay, this is called a Neer method. It's for the supraspinatus outlet. It can evaluate patients who are having rotator cuff tear symptoms. It can evaluate for narrowing of the supraspinatus outlet, arthritic changes, maybe bone spurs of the distal clavicle are crowding things. Maybe the acromion has arthritic changes and is growing spurs. All of those can be evaluated with this Neer method. So we set up like it's a PA oblique scapula, and then we switch the tube angle 15 degrees caudal, and then we switch the center to just below the acromioclavicular joint. Okay. And so can you clip off the inferior angle for this one? Yeah, because the whole, so yeah, see where that white arrow is? That's the region of interest. That's the supraspinatus outlet. That's the only thing that matters in this image. Now, I've never shot a near method, but it looks like it's a decent substitute for a scapular Y, and it also looks like it separates the scapula from the clavicle a little bit better than a conventional scapular Y. Okay. Arm position is not critical. That's what Merrill says. Your radiologist may differ. Your radiologist may want you to bring the humerus anterior or posterior to the scapular body so that they can evaluate the scapular body on this projection. But the region of interest is the very top of the Y there underneath the acromioclavicular joint. That is where the rotator cuff injury manifests, and rotator cuff injuries are often precipitated by arthritic changes at the acromioclavicular joint. So, all right. How is the affected arm positioned for the inferior superior axial lateral projection? Is it abducted to a right angle and an external rotation, abducted to a right angle and in neutral rotation, or adducted and in internal rotation, or is it just relaxed by the side? And I believe the right answer is A. I'm actually going to look this one up to be sure, because I'm really not sure if it's A or C. So give me just a second here. Position of the part. As much as possible, adduct the arm of the affected side at right angles to the long axis of the body. A minimum of 20 degrees is required to prevent superimposition of the arm on the shoulder. Keep the humerus in external rotation. So it was A. That answer is found on page 254, or I'm sorry, 240. Where did I get 254 from? 240 of your textbook Merrill's Atlas Volume 1. Abducted to a right angle if possible, and always in external rotation. All right, moving on. Your AC joints Pearson method. Why are they centered to the, that's weird. That's a sternoclavicular joint. That's not an AC joint. Oh my Lord. Oh, that's showing you where the central ray is. Yes, the central ray is directed to the manubrium. What? Yeah, we're getting a bilateral here. So your AC joints, you have one on top of each shoulder. So you're going to use a 14 by 17 crosswise. You're going to back up the tube to 72 inches so you can reduce magnification. And hopefully, if the patient's shoulders are not as broad, they will fit inside the 17-inch span of the cassette. And so basically it's like bilateral clavicles. Okay? The key is the acromioclavicular joint. The acromioclavicular joint can become separated, and the Pearson method is the way that we diagnose AC joint separation. And what we do it is one where the patient's arms are relaxed, and then one with weights affixed to the patient's wrists to pull tension on the shoulders. Okay, if the AC joint is separated, the weights affixed to the wrists of the patient will exacerbate that separation. We'll see a clear difference between the with and the without weights projection. Your collimated field, 17 inches wide, but you only need probably 5 inches superiorly to inferiorly. Okay. The center ray is directed to the sternal notch, which should be at the same level as the AC joints, with the patient standing upright and in true, they got to be, their shoulders got to be square to the image receptor and such. You don't want them oblique or rotated at all. Okay. Now, CR perpendicular to midline of the body at the level of the AC joints. That's typically the sternal notch. Not always, but typically the sternal notch. Now, what happens if you're x-raying me and my shoulders are wider than 17 inches apart? My AC joints can't be put on a single image receptor. Well, you just do them individually and you center to the AC joint. And so if you're doing a single one, center to the AC joint, collimate down to, oh look, 6 by 8 inches, that's plenty. Again, the area of interest is just the AC joint. So you'll have to do individual ones with and without weights for larger patients with broader shoulders. Okay. Oh, look, what is the required patient position to demonstrate the left shoulder in a PA oblique scapular Y? Okay, so PA, that means the central ray enters posterior, exits anteriorly, and so it has to be one of the anterior obliques. Now we just need to know what's the correct degree of rotation. So we're demonstrating the left shoulder. It's always affected side down, so it's going to be an LAO. That would mean B or D. A and C are eliminated because that is affected side up. We want affected side down. And so now we just need to know which degree of rotation is correct. Is it 35 to 45 degrees or 45 to 60 degrees? And for the scapular Y, PA oblique projection is actually choice B. Choice D would be the right answer if we were doing a Gracie method, but then you would have to change to an LPO. So 35 to 45 degrees was for the Gracie method. 45 to 60 degrees is for the scapular Y. So make sure you keep those obliquities straight and don't get them confused. All right, to do projections of the clavicle, you notice we don't do a lateral clavicle. Just think real hard about that and you can figure out why. We're going to do an AP or a PA and then an AP axial or a PA axial. PA projections are preferred because of reduced OID and improved image quality. AP projections can be used on recumbent patients. I've never seen a tech do a PA clavicle. The book says it's preferred. It is preferred. You get less OID, less magnification, improved spatial resolution, and you save dose to the patient's thyroid gland. But every tech does their clavicle series, AP and AP axial. Even me, when I was doing them, I would do them AP and AP axial. All right. So, oh, and look, they demonstrate the AP axial or the AP projection, not the PA. All right, all of them use the same collimation. You got to collimate to the clavicle. The clavicle is the most palpable, not if it's fractured, but if it's not fractured, the most palpable bone in the body. Just about every habitus, you can definitely palpate the AC joint and the distal end of the clavicle, the jugular notch and the proximal end of the clavicle, and then for most folks, except for like extreme hypersthenic habitus, you can walk your fingers down the entire clavicle bone from the proximal to the distal or the distal to the proximal. So there's no excuse for clipping this thing, okay? 3 inches of collimation superior to inferior. This is excessive. That field is opened excessively. We don't need all that field. 3 inches from top to bottom and then open to include the proximal end and the distal end. So open to include the jugular notch, the sternal notch and the manubrium, and the sternoclavicular joint, and then open to include the AC joint. So that's how you open up side to side. Top to bottom, 3 inches. That's all you need. 1.5 inches above where the clavicle is, 1.5 inches below. Center to a point on the clavicle halfway between the SC joint and the AC joint. Okay. 40 inches of SID, perpendicular tube angle. Hey, there's a clavicle. Okay. So the patient can be supine or they can stand up, usually standing up if they can tolerate it. Okay. Arm relaxed at their side, shoulders in the same horizontal plane. That makes the clavicle run mostly horizontal. Direct your central ray perpendicular to the midshaft of the clavicle. Now, exposure is made at the end of exhalation, so blow all your breath out and hold it out. What that's going to do is compress the rib cage a little bit, and so you get less superimposition of ribs 1, 2, and 3 over the clavicle. They'll still superimpose, but an expanded rib cage will superimpose more over the clavicle. So that's why we do exhalation. Okay. If we're going to do it PA, it's basically the same thing, just turn the patient around. Okay. Now their clavicle is not at the that's the trapezius muscle. It's at the very top of the shoulder. You're still centering to the clavicle, and I think this is the reason most of the techs will do the AP rather than the PA, because you got to kind of, on the PA, you got to kind of guess where the patient's clavicle is versus the AP. I mean, you're looking right at it. It's sticking out of the patient's skin. Yeah, so a lot easier to visualize the AP clavicle than the PA clavicle, but basically it's the same projection. Just turn the patient around. All right, AP axial. This is a lordotic. This is similar to the idea for the Limbaugh method of the chest, where we did lordotic chest for apices or apical regions. Remember, the whole idea of the lordotic chest is to get the clavicles off the lung fields. Well, the whole idea of, because the lung fields, the top of the lungs, those apical regions were the area of interest. Well, we're going to use the same strategy, but now the area of interest is the clavicle, and it's the lungs and the ribs that are superimposing the clavicle and preventing us from getting a definitive diagnosis. So we tack on an axial clavicle with a 15 to 30 degree cephalad angle for the AP projection. It'll be a caudal angle if you're doing the PA projection. And what that's going to do is it's going to project the clavicle above most of the lung field. The first and second rib will still superimpose like the proximal end of the clavicle, but about 2/3 of the clavicle is free of superimposition on this view. So it's a really nice view. Okay. Again, positioning, have them just lay or stand. You want them square. You don't want them favoring one side. You don't want them rotated or obliqued. You want the shoulders at the same height. Okay. That way the clavicle will be running mostly horizontal when you invoke the cephalad, 15 to 30 degree cephalad angle. Okay. Now again, why does that say 5? That's weird. Standing in lordotic position 0 to 15 degrees, standing 5 to 30 degrees. That's different than what the diagram says. Supine position 15 to 30 degrees. So I'm just going to tell you 15 to 30 degrees. That's a lot more consideration than you need to. Yes, if you put them into the Limbaugh method lordotic position where they're leaning back, you technically don't need any tube angle. So yeah, but that's not the way the texts do it. The texts do it 15 to 30 degrees cephalic, whether they're standing or sitting. Okay. Now, how much angle do you really use? Because that's a range. Well, how big is your patient? The hypersthenic patient needs less tube angle than the asthenic patient. And it has to do with, remember the second geometry lab where we were applying angles to the paper clips on the top tray and they shifted over more because of the increased OID? Well, remember I said the whole point of this is we're trying to shift the clavicle off of the lung field. Well, a patient that's hypersthenic, their clavicle in the AP projection, their clavicle is somewhere between 6 and 8 inches off of the image receptor at the time of exposure. Okay, versus an asthenic person, they're thinner, the clavicle might only be 5 inches off the image receptor. And so we know with increased OID, if we apply tube angle, the greater the OID, the more you throw the shadow off to the side, so to speak. And so the shadow of the clavicle will be thrown off to the side quite a bit with a 30-degree angle. Okay? But the hypersthenic patient doesn't need a 30-degree angle because they have increased OID of that clavicle. And so 15 degrees is enough to throw the clavicle off of most of the lung field in the rib cage for the hypersthenic patient. The asthenic patient, now the OID is reduced, you need more angle to throw it the same magnitude off to the side out of the lung fields. Okay, so the larger the patient, the less angle you need on your axial clavicle. Exposure made at the end of full inspiration for this one. That seems wrong, but that's what the book says, so we'll do that. Full inspiration for the axial clavicle. All right, doing the PA, it's either prone or standing. 15 to 30 degrees caudad exiting the mid shaft. And again, it's kind of difficult to see where that is. And that's why most texts do not do the PAs, even though they are superior in just about every way to the AP projections of the clavicle. All right, guys, continuing on for scapula projections. Please, if you haven't done so, take a break. Yes, I know this is, we're doing good for 56 slides, only an hour and a half. Right, so for the scapula, AP and lateral. Now most protocols, the lateral is substituted for the scapular Y. There is a difference between a lateral scapula and a scapular Y. Okay, for the AP scapula, you're going to do a princess wave like you're at the county fair, okay? And you're riding in the parade and you got a little sash on, okay? So the AP scapula, what you want to do is you're flexing the arm, flexing the elbow to about 90 degrees. It's not really particular what you do with the elbow, but you have to abduct the arm and raise it above the patient's head. And what that does is it causes the scapula to kind of drift out laterally off of the rib cage and remove superimposition with the rib cage. And so I always call it the princess wave because the arm is in the exact posture of those beauty pageant contestants at the county fairs that are, whoever's Wilson County, Miss Wilson County Fair, that's the one we have up in Lebanon. And yeah, anyway, so that's how I remember it is princess wave. Yeah, now you're centering for the scapula, which is 2 inches inferior to the coracoid process. So you know where the small of the shoulder is? Center 1 inch inferior to the little dip in the skin right there on the inside of the deltoid muscle. Okay, because the center of the scapula is actually lower than the shoulder joint itself. Okay. Collimation, 10 by 12 or even 8 by 10, portrait style. Okay. The humerus is not the area of interest. The clavicle is not the area of interest. The scapula is the area of interest. Okay. It says exposure made during slow breathing. No, you can have them hold their breath. Okay. I have never had anyone do slow breathing during a scapula x-ray. Okay. And abducting the arm, you get some of the body of the scapula off the rib cage. You can see the AC joint open on this view. Glenohumeral joint slightly closed, but you can still see where it is. Oh, look, we have unlabeled indicators here. So starting at the top in that picture, that indicator is the acromion. The next indicator down from the acromion, that's the distal end or the acromial end of the clavicle. The third indicator line down on this radiograph, that is the coracoid. You're looking down the gun barrel of the coracoid process. Then we have the glenohumeral articulation or the glenoid fossa. Then we have the lateral border. Then we have the medial border. And then finally, the very bottom indicator, that's the inferior angle of the scapula. Okay, and so what needs to be included? You have to include all of the scapula. So you got to have the glenoid, you got to have the AC joint, you got to have the inferior angle, you got to have all of the medial, superior, and lateral border. Okay. All right, this is how you do, yeah, this is that fencing posture that I told you about earlier with the scapular Y. It's an alternate position for the shaft of the humerus. It orients the humerus posterior to the scapula. Of course, the humeral head will still be superimposing the glenoid. This is going to look like a scapular Y. Okay? Standing or seated RAO, 45 to 60 degrees, positioned just like a scapular Y. This time, bring the humerus posterior by having them rest their forearm into the small of their back, like a fencing pose. Okay, see, I think that one looks prettier of all the ones. You know, the Neer method was good, but I think this one looks prettier even than the conventional scapular Y. It's just, you've removed so much superimposition here. You still get the Y view. AC joint is burnout on this one. It won't do that on digital. This is probably a film projection that we're looking at here. Humeral head centered over the glenoid fossa. We can see the body of the scapula free of superimposition, and we can see the space between the scapular body and the rib cage. So if there's going to be a transverse fracture, it's going to be just below where the humerus ends, superimposing the scapula there. All right, alternatively, I don't like that one. I have shot it that way, but I don't like it. You can do extreme anterior adduction, or you can raise their arm over their head, or you can do a combination of these. What this does is it changes the location of the humeral head just slightly. It's so with a combination of these views, with a couple of these projections, the radiologist can see the entire scapula free of superimposition, basically. Okay, so bring the arm across the upper anterior chest. That would be like tell them to bring the affected arm across and grab the other shoulder, and then raise their elbow up so it's right in front of their chin. And that's how you get the right hand side picture on this slide. The other one on the left just raised the arm as high as it'll go. Okay. And so same position, same obliquity, 45 to 60 degrees, same centering. Okay. Centers just like a scapular Y. All right. That is the end of that. Came in under 2 hours. I'm impressed with that. I don't know about you guys. Hopefully you didn't fall asleep. And remember, this is the lesson that kind of jumps over and carries on beyond the holiday break. So I understand holiday brain is real. Still going to hold you accountable to this eventually, but it's not going to be till January. So anyway, enjoy the lecture, and I'll see you guys in positioning lab next week for this. Take care.